So our next panel presentation is titled Heart to Heart, Understanding Cardiac Challenges in TANGO2 Deficiency Disorder. And our first panelist is Giorgio Pochettino from Italy. Giorgio is the chair of the TANGO2 Research Foundation Research Committee, and he is dad to Eduardo and Carlotta, who are TANGO2 warriors. Please welcome Giorgio Pochettino.
Hello to everyone. Thanks for being here. So I would like to speak about my son, Eduardo. I'm not going to talk about Carlotta because at the moment she has no symptoms, so she's 8 years old. Instead of Eduardo, he's 10 years old, and I would like to talk about him because he had a cardiological issue in the past, and I think it can be a good introduction. And later, from more scientific point of view, there will be a deep dive on the topic. So I would like to start from the end of the story. I would like to show you a video of, I think, 2 weeks ago, where Eduardo is at the moment. I just used the pointer. So now you can see Eduardo is with his grandfather.
Vai, Eduardo.
Mia cucina piccola ma bella. È piccola ma bella e piena di gioia.
Okay, so he was reading in Italian, of course, I can translate. So he said that his kitchen is small but beautiful. He has a small kitchen, and to facilitate, to allow him to start, because for him it's a big effort, we try to write simple sentences that are in line with his expectations. So, and to be honest, when I was here the first time with you in Houston, I was never expecting results like now. So I think it's it's a good sign for all of us. It means that we have a hope. We can see how our children can improve, and I think we have reaching a good result. This is we can see where we are. So, talking about rapid hemolysis, I would like to underline that he has a very three acute rapid hemolysis episode. First time he was 13 months old, then 27 and 28. So two of them very close. Some of what I'm going to say from you will not be new because many of our children had the same issue, and also natural history was explained that thanks to the work was done in Houston. But important to repeat what we have seen in order to avoid that something can have again. So the first episode, we can say that it was not eating, he was not drinking a lot, and he has a sore throat, but not fever, and he was getting tired. At that period, we didn't know that he has a disease, so for us it was just a quiet child, a quiet baby. So we see something strange, but it was our first child, so we didn't have experience, so we was, okay, he's quiet. And we go to the doctor, say, okay, he's a quiet baby, and was supposed to be okay. Then, during this episode, was not able to keep upright in position and lost his balance. And that time we say, it's not normal. Oh, he's not drinking any alcohol, so so it was really strange. So we go to the hospital, and he started to have rapid hemolysis. To be honest, I didn't know what it was. And when he was there, we have seen that in 72 hours, the CK was 220,000. Yesterday we already mentioned about that. And the doctor, they do the test twice because they thought it was a the machine was broken because they never seen this number. And it was really, really strange for them. They never seen it. Then what was also happening is that they tried to give cortisone, hydration, and so on, and the CK was really dropping down, and it was normal in a few weeks. And what was important to say is that we observe, and this was not just observe what was happening, it was in a coma state, so it was a deep comatose state because he has very low sodium, and it was really, really strange for the doctor because they didn't understand what was happening. And talking about cardiac complication, that is the main task of today, of this speech, is to say that there was really a complex situation. So CK-MB, so the value of the heart was really strange. Troponin T was also out from value. ECG also, and QTC long, and also the heart injection fraction was 45-50%. So it was really critical. But still, in that period, we didn't understand what was happening. The doctor they thought was a virus, and we stayed 3 months in the hospital. When we go home, they told us that probably everything will be solved because it was just a virus. But I was not sure that there was an answer already at that period because I was thinking, how can be a virus so strong and go in coma for a virus? Then the second episode he was 27 months old, so was 1 year later. Was always in summer period, and this is also natural history study was shown that the high temperature is a critical factor. He had a fever, 39 degrees Celsius, and also in this case was not drinking a lot, eating not also, and after 3 months he was tired, and he started again the rapid hemolysis. So what was happening, we have been again to the hospital. The CK was high like the year before. And in that case, they say, okay, we don't try the cortisone, just try an error approach, but they didn't know exactly what to do. They give a sodium bicarbonate and paracetamol, but they didn't know really what to do. And in this case, we can say that lactate was too high, and they start to think about mitochondrial issue, and then the cardiac complication start to become critical, but not originally not like the year before, and. Okay, there was done also the test like MRI and so on, but the main point is that we were almost ready to go home because CK was very low again, and I think was planned to go home on Monday, and on Saturday morning the situation became really, really critical. They thought this was something that they didn't recognize that he was not eating enough, because they say a baby can stay without eating also from 1 day, but as we know, this cannot be happen for our children. And so it took a infection, a viral, it was adenovirus. They discovered it was a virus. And also in that case, they say, okay, it's a virus. Didn't recognize that it was an issue, but it was a real issue because it started again to rise the CK, not as much as before, only 54,000 as a value. But what was happening is that he was again in coma, and he has a cardiac arrest. And in that moment, The doctor didn't know what to do, so they use adrenaline, morphine. They try to do all the drugs they have in the hospital, and they make me a question that it's really hard to hear. They say, we don't know what to do. Shall we continue the treatment or shall we stop? Because they have no power. They feel like in the space. And I say, let's continue, because I don't want to say, let's stop if I don't know why. I'm engineer, so I want to know reason behind. And this was a good answer. And the doctor, after he was again out of the coma, I say, there was a wrong question, because they asked me, because they are human at the end, like me. So they just asked that because they have no clue what to do. And so the answer was the right answer, we can say. And so he was okay, because he was able to get out from the hospital 2 months later. And there was a nasogastric tube to help feeding. And after that, he was able to go home. And now he's able to read and to write. So the conclusion is that I think we were lucky, because the situation was really critical, but at the end, this difficult situation gave us the power to be here, to continue, to make research. And my lesson is that we need to know before answering. So we need to really to make research, because we have to be able to recognize what's happening. And that moment, until we didn't know that it was a TANGO2, we just really react without knowing, from a scientific point of view, but also in general from the behavior point of view, what was happening. And this was really, really dangerous situation. And I think now it's time to let the word to Cheyenne Beach. Thank you very much. And just a big information about Cheyenne. She's a pediatric cardiologist, sorry for my English, and the director of pediatric electrophysiology at the Yale Hospital. She enjoys caring for patients and families and participates in research to improve the care that can be provided. Dr. Beach is a member of the TANGO2 Research Foundation Scientific and Clinical Advisory Board. Please welcome Dr. Cheyenne Beach.
All right, hi everybody. Thank you so much to this whole group for asking me to be here today, and for everybody sharing your stories today. We clearly wouldn't be here if we didn't have this group of people and the willingness to share stories. So Giorgio, to you also, thank you for sharing that story about Eduardo and Carlotta. We do want to acknowledge Carlotta as well. I am a pediatric cardiologist, and I specifically work with electrophysiology, so heart rhythm disorders. I chose this field in part because it's a very narrow field. There are 4 of us in the state of Connecticut who do what I do, and I like that because I like to know what I'm doing with confidence. I am not comfortable with being an emergency medicine physician and having somebody come in with some unknown something. I need to know how to treat what I'm looking at, and I need to be able to say that I am doing the very best that could possibly be done for each person in front of me. So my experience with TANGO2 started when I was a brand new attending, literally like 4 weeks into being an attending physician, and I was the only pediatric electrophysiologist at my institution. And I was called because we had a patient who had recently been diagnosed with TANGO2 Deficiency Disorder. she'd had symptoms for many years. She was 20 years old at the time, and she had had a brother who had passed years earlier after a very long, drawn-out, dramatic, traumatic hospitalization. And I was called because she was quite ill in the setting of a urinary tract infection. She'd developed rhabdomyolysis and was starting to have heart rhythm abnormalities. And this beast is the best way that I can describe this, was absolutely terrifying for me because I know how to treat arrhythmias. I'll talk about this a little bit in my talk, but I'm very good at managing the arrhythmias, even really scary arrhythmias that other people don't know what to do with. I know what to do with those. And everything that I had in my bag of tricks didn't work. In fact, it seemed to make it worse. And this was terrifying, that here I was watching somebody get worse in front of me. So I did what probably any of us would have done at the time. I Google searched it, right? I said, I don't even know what TANGO2 is. I've never heard of this. So I put it in Google. And the one paper that had been written, this was 2017, so the one paper that had been written with Seema Lalani as the first author, and then I knew Christina Miyake's name on that paper. And so I put my big girl pants on, and I said, I'm going to call Christina. I think Christina knows who I am. Even if she doesn't, she's about to. So I sent an email to Christina, and Christina right away said, no way, I can help you. I need to know what's going on with your patient, and we need to try to help this person and figure this out. And so I was terrified, awake for about 5 days and nights straight, because I was the only person who had any chance of saving this person. And I tried. And I couldn't save her. Part of the discussion that we had, which I'll bring up in a little bit, was the use of ECMO. We've talked about this a few times here. So this is a heart-lung machine. This is, ECMO stands for extracorporeal membrane oxygenation, which basically means a machine that can work as either your heart or your heart and lungs. And after this patient had multiple cardiac arrests, and I could see where this was going, she was not improving, I offered this to the family and told them honestly everything that I could tell them about this, which had a lot of limitations. I didn't know what would happen on ECMO. This could make her worse. This could be traumatic for this family. And they elected, after a long discussion, they elected not to use ECMO for her. I've presented this case in a couple different forums, in cardiology meetings, electrophysiology meetings. I've talked about this at one of Ryan's banquets that we had. And each time I sort of, I wish I knew what I know now. I'm very grateful that I know what I know now because I have a plan. And I talk with my patients with TANGO2 Deficiency Disorder and their families about what my plan is. It takes a lot of time to do it, as I'll talk about in a little bit of detail coming up. But I have a plan. And we're in the cardiology community where we're trying to disseminate this information so that more people have this plan and do not have to experience this the way I did. Maybe I can advance this. There we go. Okay. So I'll go through a lot of this pretty quickly. So I'm going to describe the problem in just filling in some of the holes, I think, after watching the last couple days to answer some of the questions that I suspect some people in this room may have. Then I'll talk a little bit about what we know, a little bit about what we don't know. I have one slide about what my approach is for patients and families who are experiencing this, and then next steps. So the problem. This is a normal baseline ECG. This is for the patient that I was talking to you about. And I will acknowledge also, I use the word patient. I try to use the word person as much as I can. Often in our medical discussions and in my writing that I do, we have to use the word patient. That is the most appropriate word to use, but I do acknowledge that this person is a lot more than just sort of a patient to the providers caring for her. So this is a normal baseline ECG. What I've zoomed in on here is one heartbeat from an electrical standpoint. So what we have is, we have our P wave right here. It's this really little wave. That's the top chambers of the heart beating. It's little because we don't have that much muscle in the top chambers of our hearts. This here is our QRS complex. This is the big spiky thing that you see in the movies. This is the bottom chambers of our heart beating, and it's a lot bigger because the bottom chambers of our heart have a lot more muscle. And then right here is the T wave. So this is the repolarization complex. This is the electricity resetting in the bottom chambers of the heart. So the ECG all the way across goes top, bottom, reset in a normal rhythm. The total QT interval is the amount of time it takes for the electricity to go through the bottom chambers of the heart and then for it to reset. And we measure a QT interval on every single EKG that we read. I make sure that interval is measured carefully because QT prolongation is something in the pediatric cardiology field that we see a lot. We do a lot of thinking about the QT interval. There's this thing called long QT syndrome, which is an inherited genetic arrhythmia syndrome that those of us who are pediatric cardiologists, electrophysiologists are very, very familiar with this. This is what our genetic testing panels are looking for. When we say we're going to send genetic testing for a prolonged QT interval, we're looking for long QT syndrome, which is actually not that uncommon in the general population. So we're now going to look a little bit into what the problem is. I'm really struggling with this pointer thing. Okay. So in a cardiac crisis, I liked one of Christina's slides yesterday that was the green zone, the yellow zone, the red zone. The red zone is our cardiac crisis. This is when we are emergently worried about this person in front of us. We often, almost universally, in metabolic crises, we see QT prolongation. So here's an example. I know it's not that obvious to those of us in the room who don't stare at hundreds of EKGs every day. But this is a long QT interval. This is moderately to severely prolonged. So this was the ECG at the time this person came into the hospital. She came in with a urinary tract infection, and she had an EKG, I think because she was tachycardic. I don't actually think it was to screen for cardiac complications of rhabdomyolysis, of a metabolic crisis. So already, well before anyone actually was worried about her, she was showing signs of difficulty. Okay. A prolonged QT interval, this is an example of what can happen when you have a prolonged QT interval. It basically throws off the electrical balance of your heartbeats. And you can develop this very unsafe, unstable rhythm. This is called torsade de pointe. And this is a very, very well-known phenomenon to happen when people have a prolonged QT interval. The next step in the progression of cardiac problems that you see if we don't establish a good feeding regimen and good vitamin supplementation is the beginning of what we call ventricular ectopy. This is extra heartbeats from the bottom chambers of your heart. So this is showing instability of the cell membranes within the heart. So this is a couple days into hospitalization, showing that she was starting to show worsening of the stability of her heart membranes. She was starting to get these ventricular ectopic beats, or premature ventricular complexes, we call them. So those are right here for you to see. I showed you what polymorphic ventricular tachycardia looks like. This is an example of the strip from this patient's telemetry monitor. So she was having very, very frequent runs of polymorphic ventricular tachycardia here. And then this is one of her multiple episodes of ventricular fibrillation. Ventricular fibrillation is the often the last heart rhythm that we see. This is a non-perfusing rhythm. We call this in the medical world, which means that your heart cannot pump blood effectively. So when people are experiencing this heart rhythm, they are not getting blood to the brain and the rest of their body that they need to survive. Christina mentioned yesterday that we also see heart failure. So this is basically pump failure we think of. This is when suddenly the heart is not contracting. Even if the electricity is telling the heart to do what it's supposed to do, the heart is mechanically not able to pump the way it needs to pump. And we see both of those things in cardiac crisis. And this is the scary part. I sort of tried to copy some of what Christina wrote yesterday, is that our medications that usually work great, I'm not afraid of ventricular fibrillation in front of me. I'm afraid of ventricular fibrillation and somebody playing basketball where there's no AED, but what happens in the hospital is not what scares me, because I can get rid of ventricular fibrillation, but not in these people, and this is why it's so terrifying. So I've included on the bottom here isoproterenol, which is a medication that basically increases your adrenaline. And it's scary for us electrophysiologists to give isoproterenol when somebody's having ectopic heartbeats, right? When someone has extra heartbeats, when somebody's had a cardiac arrest, when somebody's having these, we are not supposed to give isoproterenol. So we still could be in a room of the very best electrophysiologists in the world, and probably 75%, especially if we include adult electrophysiologists, probably 75% or more would stand up and say, that's a terrible idea. What, you're hurting your patient. And so I had isoproterenol at the bedside. I had it for this patient at the bedside. I don't know if it would have helped, but I didn't start it because I didn't have the guts. It was easier to do nothing, not that I was doing nothing, but it's easier to not do something than to do something that I thought could possibly make me kill my patient, honestly, is what occurs to me in my head, and I'm not willing to let that happen. So instead I chose not inaction, but I chose less action, something that the great majority of people would say, Cheyenne, that's understandable, rather than doing something that took, now I would do it, you bet I would do it, but something that took sort of an extra amount of guts to do. Atrial pacing is, we have different ways of doing this, where we're actually giving extra beats to the top chambers of the heart. Same thing as isoproterenol, we raise the heart rate that way. This is something that is not terrifying to do. I wouldn't have been worried about it, but it takes a lot of effort. We say, how are we going to do this? Are we going to put in a temporary pacemaker where we give somebody anesthesia and we put something in a neck vein? We put a cable in a neck vein that can allow us to pace the heart. We can do it through the esophagus, which requires sedation. And so it's not a nothing thing to say, hey, I'm going to choose atrial pacing as the way that I'm going to do this. Again, now you bet I would do that. And then ECMO. Now we know, we have a number of reports. We heard Bria's story of successful bridging to recovery. So we do have reason to say we know what can happen if we put you on ECMO, so that we can help get you through to recovery here, to get you through the arrhythmias. And I could not tell the family that I had in front of me that I knew that was possible. So what we know, I kept the slide exactly the same. This is what we know. This is a lot more than I knew in 2017. And so now I feel prepared. It's not as much as I want to know, but now I feel really prepared to be able to take care of my patients. Just some of the B vitamin stuff, I'm not going to harp on that here too much, because I think we've given appropriately a lot of time to that during this conference. A lot of other things we don't know. Why? Thank you to everybody who's working on this. We're starting to talk about the use of vitamins for treatment of an acute crisis. So instead of my putting some huge gun antiarrhythmic on, do we infuse some medium, high, very high dose of vitamins to try to restore normal heart rhythms? Thank you so much to Christina for working on that. And then also we started to talk a little in one of the groups I was in about SIDS, so sudden infant death syndrome, about sudden unexplained death in the young. What happens when our TANGO2 warriors are home and something suddenly happens? And it's not this, in the ICU having terrible heart arrhythmias? What's happening to these people? I think there's a lot of questions that we still don't know. I do want to show my approach. So outpatient, there's a lot of education. When I meet a new family, it's a lot of visits, a lot of discussion. I start by meeting the family where they are, and I like to make sure that they know and understand what I think they need to know and understand. And it definitely can't be done in 1 or 2 or usually even 3 visits. We talked very specifically about the vitamins, including the doses of vitamins. We make a plan for mild illness. So this is, I want you to call me. I do not want you to be wondering if you should call me or not at home. I'm very lucky to work with an excellent metabolic genetics team, and so I sort of say, also call them, but you can call me if nobody calls you back, because I'm going to make sure that you are taken care of. And then when something happens, I actually usually have them talk to the metabolic team to make sure they're doing okay. This is the emergency action plan. We go through that very carefully. Our geneticist and I both approve it, and we update it about once every year or 2 now, and we make sure that there's a new copy. One of the pointers I would like to make is please remove old emergency action plans from whatever electronic medical system is there, because an emergency medicine team will say, oh, here's an emergency action plan, not realizing it's from 2018. And the information that we have now is different from what we had in 2018. So we've been through, I'm going to use Ryan's chart as an example. We've been through and we've taken out Ryan's old emergency action plans from his chart to make sure that the one they find is the one they need. We have the ECMO discussion so that if this ever comes up in a more acute situation, that families are familiar with what this is, and we so that they're not going to be prepared for that moment if it happens, but they're as prepared as they can be to say, "Oh, right, we've had this discussion, and I feel like I'm more comfortable with their goals and their thoughts about this before it happens." And I include this in the chart. I make sure I write. At this point in time, and of course we can change our minds whenever families want to, but I say at this point the family does agree so far to the use of ECMO if needed. And then during an illness, so focus on vitamin and nutrition intake, work with our genetics team as I mentioned, and as I'm sure most of the medical providers familiar with TANGO2 do, I advocate like mad when something happens with our people. And this is a lot of provider education. So if somebody comes into the hospital and a general pediatrician who's covering an inpatient pediatric service has no idea what TANGO2 is, and they are not the group who's really going to know in the next few years. And so it's up to me at our hospital to make sure that they know. And I'm not just going to say, well, I'm frustrated with you for not understanding. If I haven't taken a few minutes to actually show them the information and talk to them about it, then they're not going to really understand. So I put a lot of work up front. I try to do everything I can to personally attend rounds for these patients. I have a very understanding partner who will cover my other medical responsibilities so that I personally can attend rounds for these people. And then during a cardiac crisis, again, focusing on this nutrition and vitamin intake. And I have had too many pharmacy people tell me something isn't possible, and I say it is possible. Part of that is, I keep mentioning Christina, she's up here too, because she's always my backup plan. Like, if I call her and say, I can do this, right? And she says, of course, tell them to, buck up. I now would use isoproterenol, atrial pacing, and ECMO bridge. I know what I need to know about this, and I'd be perfectly happy defending myself, making one of those decisions. And then, to be honest, Christina, my plan is to call you. So none of my patients are going to have a crisis. I sort of tell on other people. I'll be like, hey, Christina, in Indiana, I heard something down this street, can you help out? And Christina has her finger on the pulse of what's going on. Seema, when we've had a hospital admission, you FaceTimed. You were part of our rounds at one point so that our providers knew what was going on and you were available to answer their questions. And so from an electrophysiology standpoint, Christina is sort of my go-to, but it's this group of people too. And I know that you guys may have learned something in the preceding 4 months that I haven't heard yet, and I'm humble enough to know that that is the case. And so no one's having a cardiac crisis in Connecticut without my calling somebody to get some help with this. I promise I'm almost done, Amy. Yeah, she is telling me that my time is up. So next steps are what we've talked about today. I thought that this session that we had in the room earlier with all of these brainstorming things was awesome. So that basically can take the place of this slide. And this is mainly to point out that I think we need a two-pronged approach. One is to take those of us in this room who are soaking up as much of this as we can and participating in these studies and doing as much as we can, and how do we make it even better for all of you? And then what about everybody else out there? And so I think we need to think about that from both perspectives. And on that note, I'm going to introduce Dr. Josh Meisner. Hold on, I have to pull up my introduction. I could introduce you probably. Sorry, I'm sweating. Okay, so Josh Meisner is a pediatric cardiologist and early stage physician scientist at the University of Michigan with a clinical focus in cardiovascular genetics. He has a translational laboratory studying rare disease causes of pediatric cardiomyopathies using human cardiomyocyte model systems derived from induced pluripotent stem cells, or iPSCs, and mouse models of cardiomyopathy. He's a member of the TANGO2 Research Foundation Research Committee and has a passion for understanding the mechanisms underlying TANGO2 Deficiency Disorder and advancing the care for TANGO2 families he cares for. Please welcome Dr. Josh Meisner.
Let me make sure I have the right thing. Okay, so I'm going to do an abbreviated focus to kind of like supplement and kind of add on to the stuff that Giorgio's his story related to Eduardo and Dr. Beach's kind of history, and focus on what are some of the challenges of modeling cardiac disease and what are the importance of really translating our basic research findings and clinical research findings toward patient care and patient treatments. Great, it worked. So general disclosures and kind of an acknowledgement of the TANGO2 Research Foundation of trying to bring together all the stakeholders between individuals with TANGO2 Deficiency Disorder, or TDD, their families, researchers, clinicians, and that an all integrated process that kind of feeds into each other and leads to further advancements over time. And I'm not going to spend much time on this, but just keeping in mind, like integrating all the stuff we've heard so far over the last day and a half, that TDD is a multi-organ system disease. There's these intermittent crises, and that there's this large variability across individuals, across families, and how that feeds into our understanding of the disease and what we can do about it. So to take a step back, let's first think about, I think about there's kind of three key pillars of translating research into patient care. One is kind of getting the foundation of understanding what is the actual clinical disease, getting data from families, getting data from individuals, adding that to our registries, adding that to our natural history study. And then that feeds into some of our information related to kind of our mechanism of disease. We're able to take our insights, like the first kind of publications that are kind of suggesting some biochemical markers, metabolic disease, potentially fatty acid oxidation disorder, that gives us something to go off of in something like TANGO2, like TDD, that has very little mechanism behind it to begin with. So it kind of gives us an idea of some of the mechanisms. And then the question of how do we go from there, of potential mechanisms, testing our hypotheses, testing what is actually involved to lead to further advancements in studies. And that's the use of preclinical models, like cells, stem cells, small animal models, mice, zebrafish, worms that we've heard about, our flies. All those processes enter together, and then they feed back onto, as we kind of understand some outputs related to these models, what are the questions we actually need to ask in and integrate back into our natural history study? What do we need to actually start asking patients? That then goes back into our mechanism and kind of this feed-forward process. And as we kind of build up our greater understanding, as we build up greater model systems to be able to test these hypotheses, we're able to start to translate some of those early therapies. So in the case of B vitamins, where we get data from patients, data from our natural history study that's suggesting some sort of signal of improved outcomes with B vitamins, and some of the early work in our preclinical models from like flies, how do you actually translate that into patients? You can do that in case of B vitamins because they're safe. There's well-established literature saying that they're not going to cause toxicity, and you can actually start to make those recommendations before we have more definitive models. But as we kind of move into kind of more targeted therapies that have based on a greater understanding of mechanism that have less data for in terms of safety and efficacy, we need to have further kind of validation within our preclinical testing and kind of asking benefits within the patient population before we're actually able to move that process forward into patients. So it's this iterative kind of process that leads to further development. And it's really kind of integrating a lot of information from families, individuals, researchers, clinicians, and kind of the advancements of the foundation. So why should we focus on the heart? As is demonstrated by our prior stories, there's huge clinical importance to make sure we don't have cardiac crises. That's high level of morbidity and mortality. But it also is really important from kind of the unique metabolism of the heart. So as we kind of heard from Dr. Lujan yesterday, and as we kind of heard over the last day and a half, it seems to be that the mechanism behind TDD is some metabolic process. And heart cells have this unique physiology where they're much more highly dependent on some of those early markers of fatty acid oxidation than other cell types. So it gives this unique model for kind of teasing apart the molecular mechanisms behind that. The other component is that one of the key quantitative and reproducible findings during metabolic crises tends to be some of the cardiac phenotypes, like prolonged QT. And it's unique in that it's a quantitative measurement that is very common during a crisis, despite the huge amount of variability in the disease. So it winds up being a powerful model that can actually produce numbers, and you can look for results in terms of what are your interventions doing, what are the potential mechanisms behind that process as you're able to read out things. So the things that we're looking at in our cardiac models is looking at contractile dysfunctions like we're talking about with decreased ventricular function, as we've kind of looked at on the mouse models, looking for echocardiography and ventricular function, kind of the extraventricular beats like PVCs and prolonged QT. So they give us these nice quantitative measurements and assessments, which we're able to kind of go through the general scientific thought process of coming up with an idea, what do we think is going on, figuring out some sort of method of testing that, and then refining our process. But a lot of that is driven by what our model system is and what our output is. You need to have a very clear signal to noise to be able to measure what is the effect of loss of TANGO2, what is the effect of having an intervention, and that's highly dependent on your baseline state. So having this coordination across groups is incredibly important to understand what are some of the baseline stress conditions that tend to elicit phenotypes across multiple models. That's going to give us more and more power for further identifying molecular mechanisms, further identifying potential therapeutic targets, and potential translation towards patient care. And we've kind of heard this wide spectrum of kind of preclinical modeling, and you have to consider that there's this combination of experimental throughput, like in cells, fish, worms, flies. You have a huge amount of testing subjects, whether those are animals, whether those are cells, and you can be able to survey and kind of move through in a high throughput fashion all potential testing. But it's a little bit different in terms of the representation of human physiology. As you kind of go along this pathway towards small animals like mice, which have more mammalian physiology, a little bit more representation of human physiology, or unlikely non-human primates, you have increasing control, you have decreasing throughput. So each of the different systems allows for integration of signals across organ systems, across different things that can give you more information, but depending on your scale. So some of the advantage of animal models are that the things that I've been talking about in terms of EKG findings, contractile function is an organ system involvement, and that there can be multiple components, as we've talked about, from hypoglycemia, metabolic decompensations. It's not likely just happening in the cardiac muscle cells. It's this happening across multiple organ systems. How those actually feed into view, you can have different control of that based on the model systems that you're using. So you can allow for kind of complex physiology when you're talking about small animals like mice versus what you can do in cells. And so we'll kind of skip to kind of the discussion of but small animals are not necessarily human physiology. So like mice, worms, rats, even non-human primates are not human cells. So there's an increasing push to include some element of human physiology and human representation of the disease for doing our model systems and for some of the preclinical testing. So from a cardiac standpoint, that's using things like human cardiomyocytes. You can't go around and collect heart samples or heart cells from patients and people. It's generally not recommended. You kind of need that. So we use other systems like stem cells, where we can take skin samples from people, pull out fibroblasts, reprogram them into stem cells, and then drive them towards cardiomyocytes, towards neurons, and start to affect what are the kind of effects of potential treatments on these pathways. But there's some complications with that. So the progress, last slide. Progress is that we have had, like, this foundation and kind of the stakeholders that are all involved has made incredible progress over a very short period of time. And a lot of it has to do with kind of our ability to increase understanding mechanism through kind of multiple components of view, from our natural history study, from the multitude of animal models that are helped to replicate and validate different findings across multiple different species, multiple different cell lines, multiple different laboratories. And that's where we're going to have a lot of that advancement and continued involvement with our patient stakeholders, family stakeholders. That's it. We'll stop there.